Hello everyone, today I'm presenting the Haptic and Optic Love and I had to be a villain. Why this title? Many of you must be thinking why I have kept this title. So I would be telling about this in a short while and let's see this case. So to start with, the main incision was formed and it is always better to have a triplanar incision because your wound is more stable and you have to inject visco quite frequently so as to protect your endothelium. And to make rexes, I always recommend Utratas forceps. With Utratas, with both the limbs closed, you can gently rub on the anterior capsule, and that creates a flap. Invariably, see here, the flap is created, and then gently you have to turn it into a circular fashion. Mostly, I do it anti-clockwise, and this is the way most of my colleagues do here. And then you have to leave in grasp gently and then rotate in a circular fashion. At any point you feel that your anterior chamber is getting shallow, then you have to inject visco. And in this case I almost finished my case in 7 odd minutes, but then I realized that my IOL was getting shifted to one side, and then I had a tough time actually to manage that. Because see, your surgery is done, and because of that strong adhesion between the haptic and optic, one might land into a complication. So how I dealt with that in this case I would be showing. And now you can see I dialed the nucleus, and most of the time I recommend is the tap technique for beginners to dial such softer nuclei. And then as usual in all my cases I do modified stop and chop. So in this case as well I went in with the phaco probe and I made a small trench. Now see, I'm showing the chopper here. Many queries have been asked regarding this chopper, so I would recommend the viewers, if you want any details regarding any of the substance that I use, you can email me at Ashish Mitra 14, and I would be more than happy and willing to help you out in getting such stuffs. And see, after making a small and trench, I tried to crack this nucleus and I was able to crack. So settings I've already told in many of my videos, that you make a trench in phaco 1 and then you hold and crack in phaco 2. So after making 6 to 8 small pieces, or maybe at time 4 pieces in cases of soft cataract, what you do is you go in phaco 2 in foot position 2, and after cracking them you can just aspirate them out into the central safe zone. And these are the cataracts, they are very soft actually and they require minimal power, so you don't have to use too much of power to emulsify them. And but at times you may land up with crater handling such cataracts, so for that also I've shown the techniques how to handle such cases. And see, now after making those small pieces, how easy it became to bring out those pieces into the central safe zone. And this case actually wasn't tricky at all, because it was a grade 2 nucleus and I managed to complete my whole process of injecting IL as well in 6.5 to 7 odd minutes. But then I realized that my intraocular lens which I've implanted is shifting to one side and something was not right. Because if your haptics open properly, the IL should be well centered. So after emulsifying this nucleus, I did irrigation aspiration, and here also you would be seeing that after doing not after exactly, but while doing irrigation and aspiration at the end, you can see that cortical chunk is there, which is left behind. And at times it is easy to handle such cortical chunk with irrigation aspiration itself. All you have to do is aspirate them, and you have to manipulate the opening of your aspiration cannula with the irrigation cannula so as to just help it getting aspirated. Now see, here there is a cortical chunk and it doesn't appear so hard, so I tried aspirating it with the aspiration cannula and manipulating it slightly with the help of my irrigation cannula, and you can see it was easy to aspirate this chunk as well. But sometimes it is a harder piece, so you might require phaco probe also to emulsify. And at times what I do is, if I have a bigger chunk left, I try to crack it into two with the help of this irrigation cannula, and then maybe I just depress the posterior lip of main incision a little, and irrigation port in place, that piece actually is it comes out. See now here, it just came out, one piece was there and it just came out while my irrigation cannula in place. I depressed that lip and that small piece which was there, it came out. Now you can very well see the excess margins are seen, and I am polishing the capsule. I always polish if I see some remnant, some fibers left, because they actually help you out in the long term. There is a minimal chance of developing posterior capsular opacification. So now something about the lens which I would be implanting is that it was a hydrophobic lens, and I usually implant my intraocular lens by hydroimplantation technique. And see, I am injecting the lens, and you can see the leading haptic that is actually attached to the optic part. The trailing haptic now you will see will open up, and I at times what happens is, see, the trailing haptic is opening up and then you implant the IOL. In such cases, what I do with hydroimplantation, all you have to do is gently press the IOL and see it goes into the bag very nicely. You don't have to dial, you gently have to press it downwards. But see, the IOL is in bag, and the leading haptic which was there, it is still attached to the optics. And I try to center my lens, but again it is shifting to one side, and I would be attempting to release this haptic from the optic, but with the irrigation and aspiration cannula, I am manipulating the IOL so that that haptic gets released. But I was not aware that this adhesion was very strong, and I would be having a tough time separating this, because the IOL, even though I place it in center, it starts shifting to one side. And see now, the IOL again will be shifting to one side, and I am trying to just release that adhesion, but all my efforts were in vain, and the lens was shifting to one side. Now you can see the IL appears decentered because of that strong adhesion between the haptic and optic. So at this point I decided to inject visco and use two dialers actually to separate the haptic and optic. Now let's see what all tough time I had doing that. This case actually also highlights the importance of zonules here, because see, with so much of manipulation, you can see the bag is intact. There is nothing happening in the capsule with so much of IOL movement within the bag. And now you can see I am trying to just separate the haptic from the optic using two dialers, but all my efforts are not working, and this is a very strong adhesion. You can see the kind of force I'm applying. See this thing, see, I am engaging both the portions, the optic and haptic part, and I'm trying to separate, but the haptic is so strongly adhered that it is not ready to come out from the optic. So one has to be gentle, inject visco. And why inject visco? Because you have to push your bag behind, you have to inflate your bag, and then you have to protect your endothelium also. Although I'm working below the endothelium, and I'm injecting visco frequently so as to inflate my bag, so that the posterior capsule goes back and nothing is actually rubbing the capsule portion. This is something we are really not prepared for, because the surgery part went well, and now this, because of haptic and optic adhesion, see, I am having so much issues, and my IOL is now kind of tilting to one side, and it is almost lying vertically into the interior chamber, and part of it is in the back. So again injecting visco, and now I thought that I would be using Utrata's forceps. I mean, you can use any fine forceps to separate it, but again when I went in with Utrata's, what I realized that I might be causing a damage in the optic parts. So again I came out and used two dialers to separate it, but again all efforts were not working, and this haptic was not ready to get separated from the optics. And now you see I'm going in with the Utrata's forceps. I would be holding the optic part, and just to have that strong counter force I could provide. But as I tried to hold the optic, I realized that holding the optic part might damage the optics. But then I again came out and used dialers again instead of Utrata and dialer, and see now I would be trying again with the two dialers, and after manipulating for some time, now I would be able to just separate them. And now see the kind of force I'm applying. This was a very strong adhesion, and now see I am again pulling with those two dialers. Now my IOL is inverted the other way, and now I'm holding the haptic part, because even if I cause some problem in the haptic part, it won't cause any problem. And now see the haptic part was caught with the Utratas, and with dialer I tried to push it away, and I was successful in separating the haptic and optic. And so the title was Haptic and Optic Love. And now you can see the IOL is inverted, and after injecting visco I am just everting my intraocular lens into its normal position, and you have to inject visco. And now with the help of dialer I would be repositing this IOL again into the bag, and now you can see that after repositing into the bag, the IOL will be well centered and it won't be shifting to one side. So this was the Haptic and Optic Love, and me a villain. The idea behind showing this surgery was that even though our surgery at times is uneventful, but still we face certain situations which give us tough time, and these situations at time can be a source of potential complication. So all we have to do is do things slowly and gently, and then it is mostly possible to give a better outcome to our patients. For any queries, you can email me at ashishmitra14@gmail.com. Thank you for watching this video. You can subscribe me on YouTube at Ashish Mitra 14.